Good morning. We are very pleased to have with us today I believe the father of spiral CT, as I think it's properly called, Dr. Willi Kalender, and he is going to speak to us today about the European perspective on patient dose and CT. Dr. Kalender.
Thank you very much for a nice welcome. I hope there will still be applause and not stone throwing or whatsoever when I finish. No, I'm confident. Can you start the clock, please? Yes. There were quite a bit of discussions on both the topics CTDI and patient dose in the past, and I pointed out several times that Europe sees it's kind of different. Now, to present the European perspective here is very difficult because European is not united as the United States of America, so I might label it is a European's position, but I do not represent any organization, although I can speak for last year's 6 medical physics meeting in Europe, Spain, Italy, Finland, UK, Ireland, and so on. They all had similar troubles, and I'll show that in some of the slides. Trouble in understanding what's going on, so this is here to... Okay, well, it's appropriate to start with the disclosures. In my case, I'm a consultant to Siemens and also working with a company, my own spin-off, which both of them, of course, are involved in these issues but do not have any influence on the things which I say here. Well, why these topics again? It is clear at this meeting, the whole AAPM meeting, it's amazing how much is being said, reported on new efforts there, so it's kind of understood. But from a European perspective, is we heard from the United States that there is trouble, and I hope we are out of trouble by now, because there are some developments, but it needs to be commented on, I think. And also we hear a lot about patient dose, and there is a lot of rumors that they don't know what they're doing. They don't think that CTDI is the right values that they obtain and so on. And I think I would like to, and I think that's an effort important for Europe and the United States to help and clarify a few things. And one statement is, in Europe, there is much less of these discussions, and that may be due to the fact that there were quite a number of efforts going on early on. And this is one of the documents that maybe some of you know, and although this is actually dated 2008, it has nice data, and it above all also has data which were assembled early on. If you know at this table here, which is contained in that document, it's about patient dose assessment, and it collected data from 8 member states, and you see here it started not only in the year 2000, but also for Germany in 1992 already. And what is being collected here is, as stated, effective dose. And you might ask, well, how do they get to effective dose? But I will explain it in a minute. And what is an essential point, it is not based on CTDI measured in phantoms. We never did that. So what I will be working on and trying to explain is what you hopefully all know. CTDI is not identical with patient dose, quite the opposite. So our dose estimates in Europe, they were all done without phantom measurements. Another interesting aspect is, and I would like you to remember the orders of magnitude, the evaluations in the 1990s and the early 2000s, which are summarized here in this report, they average around 6 maybe, but taking into account all the measures we have taken in between, I would like you to remember that, at least for Europe, I hope also for the United States by now, a typical average effective dose per CT scan, averaged for all these exams here, is about 5 millisievert. And I will come back to that at the end. And of course, you all know that relates very favorably to the natural background radiation, because one thing I'm really concerned about is that people always say that CT is dangerous, CT is high dose, and when you ask what are the doses, there is just silence. And you say, you know it's dangerous, but they don't know the dose values. So communication is very important. The disclaimer I already said that when starting, I really congratulate you and myself, because I'm a member of AAPM for more than 20 years now, and I enjoy the meetings here. And we do not have an equivalent in Europe, so we don't have the authority there to state what's going on. And I would like that similar developments will take place in Europe, but in any case, what I'm reporting here is by no means a confrontation of European and US-American concepts. I think and I hope we can bring them together. So obviously, a nice setup for the talk would be to start with CTDI, separately from patient dose, then report on patient dose, what in both cases the status is and what the proposals are, and then, of course, provide you with a summary, and if there is time, with a short epilogue. Well, CTDI, I think it has been stated often enough, it is just a measure of CT scanner's exposure output, as you would do it in radiation therapy. So you have a technical parameter. It is not patient dose, by no means, and that is a problem if you mix them up. It has been introduced here in the United States. It was FDA, that will be shown in the next slide. But if you're interested in it, if you're not overfed already by reading CTDI, you can look there. And one thing which worries me kind of, IAEA, the report is excellent. It's all these reports. It has 28 equations which always start with CTDI equal to. So this seems to be a very, very difficult topic. If you have to go into so many differentiation, I think it's unnecessary, but it's good to have solid literature on it. Well, how did it start? It was started in the United States. It was SHOPE, it was the FDA, and they proposed to take, instead of the peak value for a single slice, an average and the accumulated dose for a typical exam of 14 slices. And that was, at the time, having 1 centimeter slices. It was considered a scan range of 14 centimeter. And the way it was then implemented, so the task, the goal is, of course, you have all these single slices, and if they add up with all the scatter tails, you have a higher dose level. It was called the average dose values, MSAD, I think, and that was the basis of the CTDI. And we are happy with it to some degree. That phantoms, at least, which were originally proposed, are still around, but we now have newer scanners, different things to look into. So what was done then in the 2000s, and that is really in all these reports, I think it's very well documented, it is above all that we have chosen a unique, a common integration length that was in the 1990s and so on, fine, with 100 centimeter. And an additional thing which has been defined in many of these documents, the CTDI 100, it has to be normalized always by the number of slices which you take and by the thickness of the slices. So we typically worked with 20 to 40 millimeters early on. And what I'm stressing here is this very kind of very simple, but then general formula. It gives you the integration length, and it allows you to measure at different locations. So it can be either in the center, in the periphery of a phantom, or just in air. And I will stress that again. That's a simple but very good prescription there. In addition, it was with the introduction of spiral CT. I was involved there, also with the dosimetry. The dose levels can be very easily assessed just by dividing by the pitch. And this pitch factor would work just the same, and it is kind of a unique description also for sequential scannings, which can be overlapping or which can be with gaps. And it would be then the same. You just have to normalize that by dividing by pitch. That is the state of the art, and it is documented in many places. I think it is acceptable what I state here. It is valid. It is mandatory right now worldwide. And above all, for acceptance and constancy testing, that is the everyday work. It is a robust and easy to perform solution. However, as we all know, there are some open issues with CTDI, and the issue that was most frequently addressed is what shall we do with wider detectors? But there are all three issues which I would like to address. One thing with respect to CT dosimetry, an important issue is how do we handle tube current modulation? How do we handle automatic exposure control? That is not easy. There is the wide-collimation issue, which I addressed already, and that will be the most important topic here. It arose with scanners offering more than 64 detector rows. And there is also one topic that has not been addressed at all. We have quite a bit of cone beam CT around. It can be C-arm CT, interventional radiology with flat detectors, and they go way beyond 10 centimeters. And that has not been really covered in the past. So if I go through these three topics, the first thing with tube current modulation AEC, I pointed out again and again that we would need some phantoms which are not cylindrical, because with usual cylindrical phantoms you do not get any effective cause from tube current modulation, because it is a direct derivative of spiral CT. You, in the optimal case, do the tube current modulation online in real time depending on the attenuation. So you can have any shape and the scanner will follow that, but there is no phantoms around yet to do it properly. Oh, there are many around, but there is no regulations on that. We are working on it again now, and some others certainly do the same thing. I don't think it is the most important topic. It just has to be, we need some standards for testing. I wouldn't claim that it has to be in routine constancy testing, but there is some standards needed to specify scanner behavior, to test and to compare them. The CTDI for wide collimation, that is a discussion, the topic which is discussed quite a bit, and it of course happens if you have beam widths, cone beam widths of more than 100 millimeters. Apparently the ionization chamber is too short, but it is even below 10 centimeter. There is some shortcomings, as I will show in a second. And because this situation was analyzed and described in detail by Mori 2005 and by John Boone, and these are the respective publication that many of you may know, it is just the title trouble here which really caused some trouble in Europe because they didn't understand that. Well, then it was very nicely explained. We do not have, depending on the beam width, CTDI values, fall off. Of course, for greater 100, that is very clear, but also for that it starts kind of around greater than 40, that is not nice, and apparently something has to be done about that. Now, there are two solutions which are proposed right now and that people are looking at. One was derived here within the AAPM and was published in report 111. It offers a very thorough, very good analysis of the complete field of CT dosimetry. I appreciate that. It also proposes measurement procedures and proposes phantoms either around 50 centimeter or, as shown here in one of the figures taken from the report, up to 90 centimeter. I think that is very well meant. Then again, if you know a 50 centimeter phantom is around 75 kilogram, a 90 centimeter, you really have to split them up. So I once said, and at least that was accepted as a statement, it would be a nice item in your fitness studio, but not necessarily for routine work in a radiology suite. So, and this is really why Europeans, they know CTDI was imported from the United States. They're simply afraid if AAPM, with all its authority, comes out with such proposals, it might go into effect. And that's actually why I was asked to speak up a little bit. I hope you don't mind that. So the solution proposed by AAPM, it demands heavy phantoms unless you decide on filling water tanks in a CT scanner, which I would advise you not to do. It proposes 3 centimeter ionization chambers, Farmer chambers. That is maybe a good idea. I don't mind at all. It is good, but it is not good enough to give a very good measurement of the dose profile because the resolution is limited. You can do that differently. And actually the missing part is a clear instruction of practical instruction what to do, because many of the statements in the report still to get to an equilibrium dose, you can 30 centimeter long modules of PE cylinders could be assembled adjacent to each other. So that's not really a clear recommendation. And I know, and I don't want to badmouth anyone, I know that many of you are working on these issues. And myself, I will speak for maybe you don't have to work on that. Because the second solution, which has been proposed by AEC, and it is in print by now, it's a release, that's the final draft, what you see here, the respective reference in the literature is still dated 2010, it is in print now. The goal there is, the approach is, well, if we are doing fine in the range of collimations up to 40 millimeters, for example, and that is exactly what the most common scanners are, the 64 slice with 0.5 to 0.625 millimeters, it's 40 millimeters then or less. So we're doing fine there. And if we want to, and that is what I would go for, instead of going for an efficiency of 100, and no patient can guarantee an efficiency of 100, to some degree it is meaningless because we won't have equilibrium in a patient either. So we may make life easier if we accept that, be it 80% or whatsoever. I think what is a clear demand, it should be corrected so that we have independent of collimation, if everything else is the same, that we have constant output as is indicated here. And you can come close if you measure at a reference collimation. That can typically be the 40 millimeter collimation, and you correct that. You have here the dose profile for the reference collimation. You have to correct it by the ratio of the two free in-air measurements. I think that's a very reliable one. And you measure n times t, that is a wide collimation compared to the reference collimation. I think this is a reasonable approach, and I think it does what we need, but you will have to discuss that further. Anyways, IEC has decided on that and will come out, and I think that may be helpful. It may also be helpful. Yesterday there was a very nice, very good presentation by Jeffrey Severson, and he referred to the Wild West situation with respect to new scanners which are around. There is quite a bit, and I've been concerned about that in Europe just the same. This is just a very small representation of what is there. Only these maxillofacial scanners. In Germany, there are by now more than 3,000 installed. There is no regulations on them at all. There is orthopedic extremity scanning coming up. This is intraoperative, and this is very, I think, very important, very much done by now clinically. That's interventional radiology. But there is no regulations yet how to operate, how to do constancy testing there. I'm concerned about that, and my advice or my comment simply is use the appropriate CTDI phantom. Here, for example, we use the 16 centimeter phantom, here the 32 centimeter phantom, and of course the respective IEC approach. These scanners need to have collimation just the same. They cannot always work with the widest field, so this approach can be implemented directly, but that's just my comment. I'm not an authority to enforce it. Why I'm concerned about it in looking at the maxillofacial scanners, because they are marketed very strongly. They are cheap, and they claim we are better, we are much lower in dose, and we are higher in resolution. They just refer to their detector pixel sizes, which is a flat detector, and they refer to low MAS. But if you look at the dose, in this case, it was done with CTDI measurements in the 16 centimeter phantoms to make it comparable, and with the standard protocols that were used. So here the simple old 64 slice scanners apparently at equal or essentially the same dose levels has by far the best image quality. So we need quality control for this circus of new CT scanners. And I think that's what Jeffrey Severson said yesterday also. Well, so conclusions on CTDI, I think we have a concept which I would recommend. It works, and maybe it is acceptable. There is no need for heavy phantoms. I would say that even if I get stoned, but I think it is not really what the routine work in the radiology department would ask for. What we have to worry about and look into is that is really cone beam CT, flat detector CT, because there is no regulations, not in Europe yet. If you have any, I would be very happy to hear about it and then promote them in Europe. And in general, I think we may forget the use of CTDI phantom measurements for patient dose assessment. Just use them for the quality control tasks that you have, acceptance and constancy testing. And I might even say we should forget possibly. And I will go into that in the next section, and that is patient dose estimates. How did we do it in the past? Well, there are reports. There is a very good report out there now from AAPM, also 204. There are these older European documents. I also covered it a number of times. And there are essentially 4 approaches which are commonly used these days, trying to give a hint to what patient dose values are. It is very often the CTDI value that is better than quoting the MAS value, which is also happens frequently, but it certainly does not represent patient dose, and just saying DLP is better because that's it includes the scan range and gives you a better estimate, but the numbers are in gray times centimeter, so they are not patient dose. What they're used for, that is diagnostic reference levels, and as you are only doing a relative assessment there, comparing it to recommended values, I think it's okay. Many people now refer to that also in the literature. And you know these tables, AAPM also introduced them and supports them. I think it's good. But one thing is they have to be reassessed again and again. They should be. But they should not be confused with patient dose. So the next approach that we have, that is to get to dose values, and that was in the table which I showed initially from Europe, and that is the DLP to E conversion, and that was done very early in the 1990s. It was initiated and supported and above all funded heavily by the European community. The basic idea is, if you just look at this example here of a heart, well, if you know the dose exactly, and you can do that with Monte Carlo measurements, then you know organ dose values, and you can calculate effective dose in ideal case. And as you also know the scan parameters, then you know the dose length product and also the ratio of E to DLP, and that is all we have to know about this DLP to E conversion. You have these factors K, and you get your E. And the world is fine. However, of course, it is not, because you do not know all the organs, doses to calculate E, because it is always, hopefully, a very small fraction of the body which is scanned. So we have to go a different alley, and that was always using anthropomorphic phantoms. Personally, I think a very good choice, possibly the best choice, is the ORNL phantom series, also coming from the United States, the MERT series of phantoms, which were alluded to yesterday in the honor session because of the Dr. Stephen Thomas, thank you. I thought Thomas is another first name, so I got confused here. Stephen Thomas, he worked on that. I think that is, I would always recommend these phantoms, although there are quite a number of other phantoms around. What is very good about it is they have defined organs, mathematically specified. They are anthropomorphic to a high degree. And if you use those, you can determine for any type of protocol the respective organ doses in E, and you have the DLP. So these DLP to E tables which are around, I think, make sense, but we have to be clearly in the statement, they are not giving any patient dose, not any organ dose values, and it is not scanner specific, and there are a number of still pitfalls or shortcomings, although this new one at least includes more of the pediatric range. It is not the perfect thing, I think. So it does not provide organ dose values. The third approach, which is commonly used, is there are quite a number of software packages with pre-tabulated data. Here I show those for Germany and Europe, and that you all know the Impact, the UK solution, Impact Dose. I did that in the 1990s already. I apologize if I don't include all the Americans. You have to fill me in with the respective information. These are quite nice to have, because they, depending on how they've done this, is what I did in the 1990s already. You can, of course, based on these phantoms, give respective organ doses, and that is very nice. And you can, it's very good actually for teaching. You can just change any of the parameters and you will immediately see how does it affect the doses, both to all the organs and the doses and the effective dose. And actually, we already included now the SSDE just to see how it develops. And that is a neat thing, possibly. I think they are very good for teaching instruction in general. What is needed still, they are not scanner-specific, they are not patient-specific, and just similar to SSDE is what we did is simply generate families of phantoms, and that is have medium, normal, large, extra-large patients, including extrapolation if you want, and that works nicely, gets you closer to the respective results. Similar approaches were followed here within AAPM, and its task group 204, and that resulted in the SSDE concept, that is size-specific dose estimates. So similar to what I just showed in the previous slide, you have to take the patient size into account, and report number 204 did that, and it was based on 4 different families of phantoms, at least several phantoms. And it is, in that respect, very valuable data. It just has 2 shortcomings, I might say. It is, well, it does not give you a new information about patient dose. It is only the CTDI value is corrected for patient size. So you have a patient-specific CTDI. Correct me if I'm wrong there. And it does not provide organ or patient doses. Also, what is kind of not difficult, but kind of arbitrary, you have different ways to choose either lateral diameter or AP diameter or effective diameter, and I don't know if everyone will do the same thing, and it's also not easy, as you will hear in some of the talks here at AAPM, what is the diameter of a patient? It depends on where you try to determine it. It is not a trivial task, I would say. So that results in a list of tasks that we would have to solve if we wanted to have perfect patient-specific dose estimates, which I will use the abbreviation Ph.D. for. Well, I think we have to include all scatter contributions, so we need a whole body representation so that we are sure, which is kind of like this concept to have a large phantom. We, of course, want to know organ dose values, so organs have to be defined. They are identified and segmented in many of the phantoms we have now. It's not only mathematical phantoms, there are also by ICRP now patient data sets which are segmented. But as I said, I like OR and L best. Organ and effective doses can be estimated, but we have to make sure they really apply to the patient, to the scanner, the scan protocol in question. And if you do all that, you might say immediately that's not practical. It will result in very long wait times to get the results. I would like to show you that this is easily possible to some degree. We all know Monte Carlo programs are around. This is what we published, showed at RSNA last year, and it is, appeared already in print in medical physics. What I'm showing here is this is not a CT scan. This is a dose distribution, but of course it's based on the CT data. So if you spend enough time, like 10 minutes, and this was applied with fast Monte Carlo implementation and hardware support, so you have these images in 10 minutes for the complete cardiac volume. Of course, if you are only interested in dose, you can work with a much lower resolution and much less scan time, and you have this ugly picture, but still the mean value is more or less the same, with all the problems associated with segmenting the heart or all the other organs. This is maybe one of the smallest errors which contribute. So it must not be the Monte Carlo calculation which limits it, and the problem is, how do we get a patient-specific whole-body voxel phantom? My proposal in this case, and actually we are working with that already, is why not use the acquired patient CT data? If you do that, you don't have to worry about effective diameters, lateral or whatsoever, because you can use the complete shape which is available from the CT scan for the scan range. But of course, you want the complete body, so why not amend it at the top of the scan range and at the bottom of the scan range with data from, for example, ORNL. It can be any of these phantoms, male, female. It can be size adapted. It can be CT with ICRP. So there is not a limit there. Whatever is considered in a consensus decision as the best fitting phantom family, and you choose from that. And then you simply insert the CT data there, and for Monte Carlo purposes to include scatter radiation, you have a whole body voxel phantom, and that's what I showed already. This can be handled in a minute or less with Monte Carlo, and if you do so, you have a whole body dose distribution. And what is a neat thing here, I just talked about Monte Carlo we need, and we need a phantom. Most important thing is, and that demands manufacturer cooperation, we need all parameters. It's tube current modulation, automatic exposure control, all the filter combinations and so on. And actually we struck a deal with Siemens to apply all these data in an experiment, or experimental phase on the scanner we have. So we have direct access to TCM. And you really have to be careful with tube current modulation. The results will depend on the information you have. If you assume you assume some starting angle, that is no good. You have to know where exactly the exposure started. You have to know the angular distribution. Just the same, you have to know the scan range when the tube was turned on, turned off, and not just the image volume. You have to know essentially all parameters. That can be done. If AAPM, they should really work on that, convince the manufacturers that they provide in a readable format, maybe under some NDA, the respective information. And then, of course, as you have ORNL, you can overlay organ contours. You have to check if they have to be adjusted somewhat. Then you have the organ dose values, and if you want to, also the effective dose. And of course, when you have these results, you can use the same spreadsheet as I showed before. Again, it's very instructive and very nice to see how, for different scan ranges, dose values change. I think that's the information which we need. And to see if we are good with respect to accuracy, it's kind of embarrassing to come up with numbers that good, but it was just the result of the measurements on these three phantoms here, kind of newborn, 5-year-old, and adult, not perfectly to scale, because otherwise this would be 5 times larger. And you have the respective CT images, and you have the dose distributions. In that case, we always did 3 measurements with 94 TLD chips for each of them, and it was always better than 10%. That's, of course, very rewarding. We are happy about that. But the message really is, if your manufacturer cooperates and lets you know all the parameters, I think we can be quite good. The question, of course, is, do we need 10% accuracy? It is important to know that we can. I think we have to spread the news that we know what those values are, because many people think with all the debates around, they don't even know what their dose values are. I think we have to work against that and really show some optimism, and that we are confident with respect to our statement. So we do know, and we can only know it, I think, if the manufacturers are cooperating. Assumptions are sometimes misleading, and important it is to know that, but I would never claim you have to do that for every patient. I think if we have in studies, apply such an approach, you can have tabulations and so on, because that would go way beyond what you can do in routine. So that was my statement on patient dose. Summary inclusion and conclusions is very short. I hope so. I tried to make a statement that scanner dosimetry can be handled with all the setups and regulations that we have right now for the established CTDI concepts. Established means it stays as is with the phantom and the ionization chambers. Just if you have scanners with wide collimation, then the AEC approach is recommended, that you do measurements in air. And in air measurements, I stressed that already, they are important for patient dose calculations anyways. And with respect to patient dose, that is what I call patient-specific dose estimates. It is important that we can come up with numbers which are really specific for the patient, under consideration for the scanner use, for the scan protocol used, and that if we include that in respective software, we can provide the respective dose values, true patient dose values. To enact all that, I think we need international cooperation, so I'm here just to maybe stimulate your thinking further. You have done quite a bit, but this is with just one or two more clever publications, that's not enough. This is really a bigger political effort to involve the manufacturers and to get the respective support there. So I just see on my controlling clock here, there is a few minutes for an epilogue or afterword. That's kind of a personal thing because I've been now in CT for more than 30 years. I had to discuss those questions very often. It was never a problem in the 80s. It was never a problem in the 90s, definitely not in the United States. We were not worried about. But right now, dose is seen as a big problem. My statement is a very simple one here. It must not be seen as a problem. Of course, if I were politically correct, I would just say ALARA. ALARA is perfect. ALARA is fine. The risk should be as low as possible. However, we run into a trap there because we will always be held responsible. Can you guarantee that the risk is zero? You cannot do that if you walk over the street here to the convention center. You cannot do it with radiation either. We just know, we know for sure that, or start with the dose values are now pretty low. That is what we know. And I think that is really what we have to tell people. We know the dose values around. And the first table which I showed from this European report, which I concluded there, an average value today of 5 millisievert might be a good bet. I think it definitely is. So that was in 2010. I came up with this table here, with the advent of, for example, iterative reconstruction, all the other things which we have now, tube current modulation, optimal spectrum selection. We have quite a number of means to reduce dose further. And we know that. I could show you, I didn't think of it, I don't want to make a radiology show, but we just have one slide with a cardiac CT examination in a flash mode that is very high, that was with 0.27 seconds exposure time. It is full quality, and it was done at 0.07 millisievert. So, but that is, I don't think that will happen everywhere, and it doesn't have to. But if we look at all these possible reductions, and many of them are in effect already, we can get to a reduction from 1 to 0.2, which is 50%, which is a factor of 5. So from the 5 millisievert, which we had years ago, it would go in the direction of 1 millisievert. And in Erlangen, for sure, pediatric and cardiac CT is sub-millisievert by now. And this has also been documented that sub-millisievert is an option. There was a workshop at NIH last year in Bethesda, and it was all about sub-millisievert scanning, and in the very near future, you hopefully will be able to read that manuscript in print. So I would like to stress we are working in the very low dose range. So the big thing is always, well, what is the risk nevertheless, and how do we communicate it? I think the communication is very problematic if we talk about is the risk zero, how low can we get ALARA, and so on. I think there is a general statement which actually at this conference I really enjoyed. It's Bill Handy and others, Cynthia McCullough, they talk openly about the risk and what scientific evidence is there behind it. I conclude, or I know I learned that long ago, there is none. Nevertheless, we have to be careful, we have to be cautious, but I think it's an acceptable statement, the risk is not known. But if anything, we know it's very low. In opposite, we know that the benefits are very high. We rescue, we save lives every day. And that is kind of forgotten about completely. So my call up for you is, you should not talk about ALARA, but about AHARA. Because it is you will never have a risk equal to zero. So as low as reasonably achievable is misleading. You have to make sure that the benefit to risk ratio is high as reasonably achievable. You can do that if you watch the indication. Of course, we don't play around. We don't scan patients at unnecessarily high exposure rates. We do everything to lower the exams, and that has to be communicated to the public, I think. So my claim here, or my suggestion is AHARA. And if that catches on, maybe we're out of lots of trouble. There is a very personal final statement, kind of hope for Europe, for myself. We need international cooperation. I already stated that. And with all these concepts, SSDE, now Ph.D., what I presented, I think it might be good if they can be merged, because medical physics internationally should speak with one voice. I would be very happy if you include me in the chorus. And what I stated initially already, that's simply the case. European unity has not been reached, neither politically nor for medical physics. We have many small societies in each member country, but not an European society of physicists in medicine. So that's what I'm dreaming about, and that's why I'm here to learn from you. Thank you very much.
Really nice talk, Willi. Thanks. I wanted to explain a little bit about size-specific dose estimate and where I think it's going to wind up being used. We've done a little bit of work in 10 patients measuring with TLDs in vivo organ dose in virtual colonoscopy cases. Not pleasant, but possible. And what we found was that in 9 out of these 10 patients, the SSDE that was calculated from CTDI vol and scaled with the patient size wound up being within 10% of the organ dose that we were measuring with TLD. So I think what we're going to see is that SSDE is going to be pretty good for organ doses across the section, maybe not at the surface, but certainly in the section. I think it's going to be pretty strong for organ dose. Of course, with tube current modulation, you would have to sort of scale the CTDI vol by the MAS in that particular plane, which makes the measurement also not easy. So it's not something that's going to be automated and, push a button, done kind of a thing. But on a patient-by-patient basis, case-by-case, if you really want to know what the organ dose is in a specific patient, SSDE will probably get you a pretty good estimate there.
Well, you did measurements on patients in vivo with TLDs. How many and how many organs?
Only one, the colon.
No, I mean, not the number of patients, but how many
10.
TLD chips, because with ICRP, you have many organs that you're concerned about.
Right. Yeah, that's for sure. We used 2 capsule TLDs. Each capsule has 2 measurement locations, so really 4 measurements per patient, and all in the same spot. We were really only looking at colon dose.
I'm happy to hear that, these validations. Nevertheless, we need, as I said, maybe merge concepts whatsoever, but you have to then really state organ dose values, and I think it will be kind of difficult if you have just CTDI, if you correct CTDI for size, then to give organ dose values. I would suggest that Monte Carlo-based tabulations should be used.
It would be interesting to check that out. These colon measurements were all very central. So I don't know how far away from the center you have to get before it sort of falls apart. But that's where some of the modeling might help us.
And you always have to keep in mind the scan range, which is a very important part of it.
Well, certainly everybody has the trouble if the entire organ is not covered.
So all I'm trying here is to suggest easy solutions. And TLD. I hate TLD since 1970s in Madison, Wisconsin. It is.
I am with you 100%
this was a
on that one.
true statement, and I gave up on them in 1980s, 1990s. Now with all this work and all the questions that come up, we went back to TLD. I really regret, but we don't have anything better.
No, I totally am with you there. I don't like them any more than you do, but for some very specific applications, they work pretty nice. Where I'm having trouble with some of where you're going is our dependence on these mathematical models that just don't represent people very well. I don't. Maybe it's just my intuitive roadblock. If we can do a better job of measuring things in real people, I'd rather, I guess, go that way than rely on these very non-human looking mathematical models that I have a hard time relating to, I guess.
Shall I blind them out?
Yes.
But I appreciate the SSDE, which is similar. We have to take patient size into account. There's certainly agreement.
So I don't want to read too much into the results of TG204. It was what it is, and it was only meant to be an approximate way of getting closer to the dose. But you said, correct me if I'm wrong, and so it is not really a size-adjusted CTDI vol, because it's got the F factor in there, so it converts the dose in air to the dose in tissue, and it also accommodates the length of the scan, so it's not for 100 millimeter scan length. So it was effectively an intent, and 2 of the 4 groups that contributed to that you showed an image from were Monte Carlo dose estimates in organs, really, especially Mike McNick-Gray's work. So that was sort of what the intention was. It was dose in tissue, dose in organs in Mike's specific case, and normalized essentially by CTDI. So I just thought I'd point that out.
It is dose in tissue. I accept that, and that's a very good thing. So it's size specific, it's dose in tissue. I didn't find where I can adjust for the scan range or the scan location.
So it took into consideration scans that were typical in length for the size patient as the size scaled. So it was typically like a 30 centimeter or 40 centimeter for a bigger diameter patient, and that number went down. This is really Cynthia's data, I believe. That number went down as the diameter went down too. So it tried to take into consideration. It wasn't meant to do everything. I'm not trying to sell it, but it was a first attempt at doing that. And clearly we've recognized in the CT committees that we've been having at this meeting, we need to do that, a better job for the head and the neck and the chest as well. And I've been calling that TG205, but I'm sure that's already taken. But the CT subcommittee for the AAPM that Mike McNick-Gray chairs, I think it will look at that when we find someone to appoint as chair.
Thank you.
Dr. Kalender, I'm really encouraged by the approach that you mentioned to estimate patient-specific organ dose, which is to take the patient's CT data and supplement it with mathematical phantoms. I'm really encouraged by this approach. I'm wondering if you could comment on how patient-specific dose estimate should be recorded and reported. Should we include the dose to all the reduced-sensitive organs, or should we come up with a patient-specific effective dose, which is not well-defined because the tissue weighting factors are averaged over gender and ages? And when we use this dose estimate to optimize protocols, what dose should we use? Should we use dose to a few particular organs or use effective dose? Could you comment on that?
I will not make any prescriptions there. I feel I'm a physicist. I'm responsible to provide all the dose values that may be of relevance and then let medical experts choose from. Personally, I learned 2 things. That was in the 70s in Madison, Wisconsin, that TLD is a pain. And the other thing was effective dose. John Cameron always said it's a lousy concept, but we'll use it until we have something better. So at least it condenses it to one number, which is reasonable. It is not all specific. So that's why I always give both organ doses and effective doses, but I know there are all kinds of preferences, and I don't want to dictate this or that solution. Okay. So forgive me, I have no clear answer on that.
Okay. I just have another question, if I may ask. You mentioned about as high as achievable. How do you think we should assess the benefit of a CT scan?
That is very difficult to quantify. There is quite a number of people who try to come up with man-years saved due to the CT exam, which comes to the right conclusion diagnosis. I go by my belly feeling. I know that there are so many cases which you know about that you meet like on a daily basis where there is a very good outcome for the patient. To quantify that, I find it difficult. Again, I just retreat. I'm just a physicist, and that is too difficult for me. Guessing, I don't like guessing. I rather measure.
Give it a 12.
Give it a 12.
I was curious, especially with this, actually the research you've got up on this slide, if I may have to wait until the paper comes out, but I was wondering, given that you've got the TLDs and you've got several different sized phantoms, if you did look at what the SSDE would be for these particular scans and comparing that to the TLD measurements of what the organ doses might be.
We would like to. This is work in progress.
Okay.
And actually, that's why I pointed out we should cooperate on these questions.
I'd be very interested.
Not compete. I think it would be better we come to a consensus and make a recommendation, US, European, whatever.
I'll be very interested to see that, because I've seen good agreement between average organ dose and calculated by a Monte Carlo program and SSDE in the abdomen over several organs. So I'd be interested to see with the TLD measurements how it all turns out.
Well, that's maybe an answer to that comment. That's also to John. Of course, I accept everything you say. I just think it will be easier for people if it's done kind of all automatically. If you take the CT scan into account, which can be quite different, even if you have typical ones, I think people will feel more comfortable if the actual range is used. And so if we combine that, it might be easier for the user.
Well, if there are no further questions, let's thank Dr. Kalender again, and